Welcome to the Beverly Hills Plastic Surgery Podcast. This is Dr. J. Calvert signing in today to the last few episodes in the Podcast One studios, along with my amazing co-host, Dr. Millicent Rovelo. Dr. Rovelo, how are you?
I'm doing really well. How are you?
I've got the news we're moving.
I know. We're changing up our studios. Still Podcast One, but in a different location. A swankier one, I do believe.
I think so. I mean, we'll see what the future holds for us. But hey, you know, we like the studio. It's worked well, and we're going to stay with the plan and see how this kind of pans out for us.
Yes, agreed.
Well, today I got a tricky topic, and it's something that came up because I was talking to a patient who came in for a cleft nose repair. Mm-hmm. It's a adult, which, you know, children with cleft lip and cleft nose and cleft palate go on to become adults who've had them repaired, but there are sometimes issues.
Correct.
And so I realized we did not have a podcast about cleft nose and how to manage this in the adult setting. I mean, and I can talk about it for children too, but I rarely get called for the kids. That seems to be like a craniofacial center kind of deal.
Right.
And so this is something I think that's really important to know about because I have a ton of patients who have late cleft nose issues that need to be handled.
Yeah, and it's not uncommon that we see these patients because typically when you have a patient that has a cleft lip or a cleft palate, and I think most people know what that means, is when you have a hole or a widening of your lip, the palate being the inside of the mouth. Those are usually fixed at birth here in the United States. And they typically go to a craniofacial team at a children's hospital, and they have the audiologist and the speech therapist and the nutritionist, and they have the whole team taking care of this cleft patient. And there's a certain order that their surgeries are done in. Usually it's the lip, and then the palate, and then any other kind of bone work that needs to be done. Like they're very set ages when all of these repairs happen, usually within their younger childhood years. The nose, however, is usually put off for some time because the idea is you want the full bony development of the face to happen before you attack the nose. And in women and girls, that's like 15, 16. But in boys and young men, it can be 18, 19, 20. So a lot of times they do have their initial nose surgery within that children's hospital setting, but a lot of times they age out of it either before they've had their surgery or before they've had a chance to maybe get a revision if needed.
Yeah, I mean, that's the bottom line is that there is sort of a protocol and plan for children with cleft lip and cleft nose and palate. And, you know, so just for our listeners, let's kind of go through what a cleft nose is,
right.
why people have them. And by the way, it's Friday afternoon, so
which is unusual for us.
Yeah.
Usually we're here on Wednesdays, so we decided
it's time to celebrate.
Time.
Cheers.
Cheers.
There
Cheers.
Yeah, we got to have a little champagne with our because it worked well for our 200th episode.
It worked well, and it's
we had some
Friday.
fun.
So.
And this topic is one of it is a difficult topic. So I think the important part to understand with cleft lip and nose that when a child is born with a cleft lip, they come in a lot of different shapes and sizes. There can be something as minimal as sort of a microform cleft, which is almost just like a split through the muscle, the lip itself, and rarely involves a lot of the nose, but some of it. It can be the nasal sill, it can be the into the septum, but then there are very wide clefts where there can be almost no septum. You know, the lip is very far apart, like even in a child, a centimeter, even more than that,
right.
15 millimeters.
Because that split, that cleft, goes all the way back in the face and in the skeleton of the face. And it's not isolated necessarily. It's just the soft tissues of the lip. Yeah,
there's a big bony deficit, which we do all sorts of pre-surgical. There's all. I don't want to get into the weeds on it because we're here to talk about the nose, but there's ways to line up the bones and that really make the lip repairs a lot better these days. But the nose is kind of an afterthought. A lot of times it's just like, well, do the best you can with it. And some of these people, really are kind of relegated to having a lot of rhinoplasty down the road just because fixing noses on babies where the bones aren't there, the cartilages are soft. There's really not a good way to do a cleft nose repair in a young child.
No, they're. I mean, you don't have to have a medical degree to acknowledge that a baby, infant, child nose is just squishy. There's not a whole lot you can do with it.
It's mush.
It's not formed yet at
No.
all. Yeah.
And so as these people develop and grow, they can wind up with Lefort 1 osteotomies where because of the cleft repair, so there's an important distinction. If you don't repair the cleft lip and palate, then the face grows normally. Their maxilla they grow up with their cleft and their maxilla is normal size. If you do the repair, the maxilla does not grow as normally as it would have. And so a lot of times we wind up basically cutting the upper jaw off of the face essentially and releasing it so that we can move it forward.
Right.
And that's called a Lefort 1 osteotomy, which takes a toll on the nose. I have tons of patients who've had Lefort 1 osteotomies for not only clefts, but for malocclusion of their teeth, where the teeth don't come together right and they need to move the jaws around. And their noses are demolished as part of that deal because you have to cut the septum off of the maxilla to move it.
Yeah.
So these are things that play into adults who come in with nose problems, nasal issues, their airway, the look of the nose, the nasal sill, the maxilla, everything resulting from the cleft that they need repaired.
Yeah. Yeah. And it's a problem. I mean, these are not easy noses by any stretch of the imagination. This is not a typical rhinoplasty. It's not even a typical revision or a secondary rhinoplasty. Like the whole face has really been not demolished, but it's taken a hit. Not to mention all the scar tissue that's there, the structures that are asymmetric and kind of warped in one direction versus another. So there's all kinds of issues going on, and this is not a chip shop by any means.
No, and a thing to remember, and this is what I teach the residents and I teach the fellows, the cleft tissue that is in the cleft is abnormal. It is not normal tissue. And so to treat it as such when you're trying to do rhinoplasty typically results in problems. And I see this all the time. It's the same almost with like trauma. When people have had nasal fractures, well, they didn't have a nasal fracture. They had a face fracture. They broke their maxilla. They broke the nasal bones. They broke the frontal bone. They've broken their face.
They crunched their face.
And it's not just a nasal fracture. And then they come in and they say, oh, we're going to do a rhinoplasty. And then the wheels come off. And nobody knows why. It's a big mystery. So I'm trying through this podcast to get out the word that when you're operating on people who've had problems with their nose due to congenital disease, trauma, or previous surgery, the operation is not simple. It is now at an ultra high level of complexity that needs to be considered when planning the operation.
When planning the operation, but also from a patient standpoint, expectations in terms of how long the recovery is going to take. Your recovery time is doubled, tripled, and you're at a higher chance of having a revision because it's going to be really hard to get those cuts and those grafts to heal how you want them to because all of those forces are going to be pulling on it in off directions.
Yeah, and that's for real, and that's due to the previous issues. So this patient that came in, I said, we're going to do a podcast about this so that you can kind of get to the nitty-gritty of it because she's had multiple operations, as you'd expect. And, like, the nose is completely gone. It's, like, washed out. Like, she's lost tip projection. There's it's not a good result from her previous operation. And, interestingly, went to an extremely competent surgeon.
I'm sure.
Somebody who's really good.
That doesn't always mean that it's going to be a great outcome because there's so many things you can't predict in the healing period, Well,
and I think it's just so there's, as surgeons, people think that there's some manual that you go to and, it's like a car, the brake lights are out. Okay, let's go to the car manual and we'll get the brake lights fixed. And you do it this way and that's how you get the brake lights in. In surgery, when we are presented with a problem, whether it's I would like breast implants, I would like a nose job, I need this repaired, I need this, this tummy tuck thing that's not right redone, my C-section scars, it doesn't matter what it is. If you put 100 plastic surgeons in front of that problem, you are going to get 100 different answers on how to do it.
And because we're plastic surgeons, all of us believe ours is the right way.
Well, duh. It is. But that's the truth, is that you will get 100 different answers. And some of them will be similar, and there's generally a way that people approach it, but the nuance, this is something that I've come up on with my fellows lately. With the fellows that we train, I think we do a really good job with them. I think the fellows are learning a lot. But I think that how the next level for me in education of not only patients and not only other surgeons, but our direct, our fellows, the people that are looking to us to really get them to the next level, training them in nuance, in how to make something spectacular. Like that's, I think when people come to me for a rhinoplasty, they're not looking for they want a good rhinoplasty. They come to me because they want it to be spectacular. They want it to wow them out of their seat, and they should, because it's their face, and that's what I'm trying to do for them anyway. And so, how to train that, it comes not only with education of the patients for them to understand it, but there's so much to surgery in terms of how we really line up the cases and teach our patients what they're up against, and teach our the fellows and the residents and our staff who help us. And there's just so much to it, and because it's somebody's face, it matters. It matters so much. And I when I see a result like this, where I'm just like, man, that guy's really good. How did this happen? How did she go from I have a kind of C- result to now it's a D-. How did that happen? And she picked somebody who's it makes me go what's the miss? Did somebody not pay attention that day? Is the teaching not right? Where's the information fail? Because the key for us in plastic surgery in the future is to create intense reliability of these operations. I think that's where we're going.
It's pretty heavy.
Well, it's cleft lip and palate. I'm very passionate about it.
Sip of my champagne here after that one.
I mean, it wasn't a rant.
It wasn't a rant.
It was
heavy.
It was a dissertation.
Yeah. I feel like I need to step up for this one. Okay.
Yes, you do. That's very important.
Or just have a sip of my champagne.
Yeah, or just realize it's Friday, and I'm like, I'm very reflective
on
today.
Friday. I know. I
am, because this is one of the fellows had an interview, and before he got on this interview, he was telling me sort of his strategy, and I go, no. I just said, no, that's not how you do this interview. And we walked through it, and I said, don't you think it'd be more powerful if you came from the position of how can I help? How can I help? Because obviously they want him. This group that's interviewing him, they want to hire him for sure. He's excellent. He's top notch. Both of our fellows this year. I mean, who wouldn't want them? Right. But his approach to the interview, when he told me his strategy, I was kind of like, no, you have to dump that. And I really want you to understand that when you're interviewing, you want to be open to the possibility of not just what you're talking about, and not just the money, and not just the how many days in the OR, but how is this going to be a lifelong, how am I signing up for something that is it's something that's going to have impact, that I'm going to change the face of the blah, blah, blah where he's interviewing, and how he's going to, just become something that's so how is it going to be better when he's left, when he's done, and that, because you have that opportunity, right? We all do. And so I just kind of listened to his strategy and sort of his thinking, and I was like, no, that's not it. You need to give. This is about providing, And again, I hate that word provider, so we're not providers, but you do, in that situation, you really have to kind of be aware. And so my point of all that is that as I listen to patients and I try to assess their situation, especially with these clefts, because I see so many that are so bad. I mean, you remember the country of Canada hired me for a patient that had been to 9 different craniofacial centers in Canada and got worse every time. And then we fixed them in one shot. And it's just how do you do that? And the way that you do it is you have to take your time. You have to really think, and you have to really be in the moment of what happened here. These revisions are hard. They're really brutal. And if you aren't careful with them, they don't turn out.
Yeah, I mean, that's 1,000% true. So the take home, I guess, for the patients is go to someone that does these, like a lot. And there are a number of surgeons out there that do revision rhinoplasties and do excellent rhinoplasties. But maybe you also want to ask them if they do cleft noses, because that is a totally different ballgame.
It is. It's really specialty.
Revision rhinoplasty per se.
Yeah, I mean, you trained at USC. You guys did cleft lips and noses out the gazoo.
Children's Hospital Los Angeles, CHLA. Yeah.
It's huge over there.
It's huge.
It's constant.
It's what they do.
Right?
Yeah.
But again, the nose is like you don't see adults at the CHLA. You do the best you can with them as kids because there's not a whole lot to do, really, is there?
Yeah, no, we would do the noses, their primary cleft noses, in their late teens before they aged out of the system. But then we wouldn't really see them again. They age out depending on the place at either 18 or 21. So if they needed a revision, a lot of times we wouldn't know because they'd already aged out and couldn't come back there anymore.
And that's who we're talking about are those, people who've gone on and man, here's the funny thing is one of my patients goes, you should have a whole section on your website about cleft nose repair. You do a lot of this.
Yeah.
I'm like, okay, will you sign for me to use your photos? Oh, no, you can't use my photos.
But like somebody's photos
but somebody
you should
can use it. I was like, yeah.
Herein lies our problem.
All the same.
It's happened so many times.
All the same. Like, I don't know what that is. I get it. You don't want to see the before because the before usually isn't that attractive. That's the thing. The afters are good, but the befores are like, I've had patients who would sign, you can use my photos, and then they look at their before and after. They're like, nobody can see that before. Nope. My friends are on your website, and nope, they can't see it. You need to take it down.
Yeah. Although to be fair, not that many people look at websites unless they're looking for a surgeon, and then they want to see that. And
I know.
It's very rare that somebody recognizes somebody on a web page.
I wish I could say that's true.
Yeah.
I mean, half the kids from Beverly Hills and Newport Beach are like, oh, I saw my friend so-and-so on your website.
Yeah, well, that's a small community.
It is. It's
a small community.
Especially Beverly Hills. I've done a ton of the noses here and Newport because it's between Corona Del Mar High School and Mater Dei and, there's just so many surgeons that they can go to. And so I wind up doing a percentage of them, and they see their friends on the website, and they're okay with it. It's cool.
They knew they got a nose job. I mean, It's kind of hard to hide that when you're in high school.
Yeah, when you come back after Christmas break with your splint on your nose.
Yeah, it's kind of a giveaway.
Okay. Yeah, I guess this happened.
So you got a Christmas present. Yay, you.
Well, so back to the clefts. I think that's really the key is just understand that there are specialty, there's a lot of considerations that would cause you to make sure that somebody's really they got it. They understand it, and they need to be in it to win it in terms of how they're going to reconstruct it, knowing that the tissue's abnormal and it's going to be the best it can be, but it can't be all that it could be without the cleft. And that is a really important point. The cleft, the shadow of the cleft, and the ghost of the cleft is always going to be there.
Always going to be there.
Always.
In it to win
sucks.
it. That should be the name of this podcast. In it to win it.
Well, maybe we'll do that. But for now, I think I don't know. Is any more about the clefts, or are we
No, otherwise we just get into the weeds of the repair, and that's just not the point.
Yeah. No. Okay. Well, anyway, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.